Okay, good afternoon again. Thank you all for joining us for our webinar brought to you in collaboration with the Ethiopian Medical Association titled Primary Headache in Pediatrics with our guest speaker, Dr. Behaylu. Before we proceed, I would like to say a few introductory remarks about Yetena Weg. So Yetena Weg is a volunteer network of healthcare professionals that is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. So we currently have more than 70 active volunteer members spanning across 5 different countries and counting more. As you can see from the picture at the right upper hand corner, this is a picture showcasing some of our volunteers at a recent get together. So our projects and engagements can be seen in 4 aspects. The first is health promotion, which is done via discussion and article writing concerning the health of the general public, health policy and its implementation. Our next is our community engagement, which includes inclusiveness, equity projects, and fundraising campaigns. Our third and one of our biggest projects is our mentorship and skill sharing, where we provide direct mentorship, soft skill, career and professional development webinars to healthcare professionals. Our last is our medical education, which under it has the continuing medical education, research and quality improvement projects. So this is another slide showcasing our program. So we previously had Clubhouse sessions. We've currently migrated to Telegram live sessions. We have CME sessions, mentorship, health advocacy, research and quality improvement webinars and projects. This is another slide showcasing some of our Clubhouse session, podcast episode, and Telegram live sessions, which is done by our health promotion team. And these are some of our activities, including mentorship webinars and workshops prepared by our mentorship team. And this is another slide showcasing the work by our health advocacy team, which includes inclusivity, sign and language training, Clubhouse discussion sessions, blood donation drives, and other workshops. So one of our other engagements is the Yetena Weg Health Article Writing Competition, which is done in collaboration with IMSA. The fourth round was announced on September last year, 2024. Roha Medical Campus, through its Roha Health Foundation, will award travel grants for 2 health article writing competition winners, and Yetena Weg will award pulse oximeters for the top 20 winners and litmus stethoscope for the top 3 winners. The top 5 winners will also get internship opportunities at Roha Health and other partner institutions, and the winners will be announced shortly. Our other project through our quality and improvement is the Yetena Weg Roha Research Fellowship, which is done in collaboration with Roha Medical Campus, with the Anbessa Specialized Hospital, and with St. Paul Hospital Medical College. The winners for the first round had already been announced, and the second phase is already well underway. When we come to our CME sessions, our CMEs are freely accessible, and yet in our partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We invite renowned local and international speakers. We've had 39 CME webinars in the past year, and our average webinar attendees spanned from 150 to 200 healthcare professionals. In 2025 alone, we plan to have more than 30 webinars focusing on emergency surgical and medical cases, ENT, pediatrics, OBGYN, and more. You can access our previous CME sessions by going to our Yetena Weg YouTube channel. And you can also get updates about our upcoming CMEs by joining our Yetena Weg Telegram channel for healthcare professionals and by following our social media posts, the links of which will be shortly posted in the chat box. And in order to get a better experience, we urge everyone to send their questions to the Q&A or to the chat box. And at the end of the webinar, they will be addressed by the guest speaker. And in order to get CU certificates, you must fulfill the following set of criteria. The first is attend the whole session virtually. The second is fill the Google form for personal details and attendance. And the third is get 50% and above on the post-webinar quiz. As usual, we have a dedicated Telegram group that's created, the link of which will be shared shortly. So you can access the quiz link from there as well as directly here from Zoom. So that is all about Yetena Weg. So our guest speaker today, Dr. Behaylu. Dr. Behaylu Yibe earned his medical degree from Addis Ababa University, followed by specialty certificate training in pediatrics and child health. Furthering his expertise, he completed a subspecialty in pediatric neurology training through a joint program between Addis Ababa University and the Aga Khan University of Kenya. His dedication to medical education is underscored by a certification in effective teaching skill for health science instructors. Dr. Behaylu is actively involved in curricular development, student coordination, and professional training. He is a board member of the Ethiopian Neurology Association and the founding fellow of the East Central and Southern African College of Pediatrics and Child Health Early Child Development Curriculum Committee. His contributions extend to research, peer-reviewed publications, and advocacy for epilepsy awareness through media engagements and community outreach. Dr. Behaylu has received multiple awards, including Best Resident and Best Teaching Resident recognition, reflecting his commitment to medical education and patient care. Beyond academia, Dr. Behaylu volunteers with Care Epilepsy Ethiopia and provides medical support to orphan children. Dr. Behaylu, it's an honor to have you with us. Please proceed, and thank you.
Okay, thank you very much, Yetena Weg, and also our participants. I'm very delighted to talk about primary headache in pediatrics. This is a topic while I have done my postgraduate and postgraduate fellowship study about the knowledge, practice, and attitude of pediatrics resident in the evaluation and management of pediatric patients. I will share with you my slide, and we'll continue our discussion. So, should I start or?
Yes, doctor.
Yes, please proceed.
Okay. So our talk on today is on primary headache in pediatrics age groups. This is the outline of the discussion. We will talk about the prevalence and impact of primary headache from a study done in Ethiopia and pathophysiology of primary headache. Specifically, we emphasize more on migraine headache because which is a disabling type of primary headache in pediatrics age group. Then we will see key features differentiating primary headache from secondary headache. Then we will define characteristics of primary headache and evaluation of patient with primary headache. Then finally, we will see the management of primary headache, mainly emphasized on the management of migraine type of headache. So worldwide, the prevalence of migraine headache in general, significant number of children report having headache at some point in their lifetime. Before puberty, boys are more affected than girls, but up to 51% of elementary school children and at least 75% of adolescents report previous episodes of headache, which means at least one kid in your family member, will encounter having a complaint of headache. From this, about 2.5% of young elementary school children and 15% of adolescents experience recurring headache. So our talk is more about the one with recurring type of headache. So this is a study done by our colleagues, Dr. Yared and his group on the prevalence of headache in school children and adolescents in Ethiopia. And the study was done on 2022. The gender and age-adjusted one-year prevalence of headache was 72.8, nearly 73%, which is a huge number. From that, females were more affected than males and more common in adolescents. Migraine account around 40% of the sufferers, and followed by tension and undifferentiated headache. So this tells you there is high prevalence of primary headache in school-age children, and most of the patients we are seeing in our clinics are the one who suffer greatly and those who develop disability following the headache. So this tells you the magnitude of the disease of primary headache in pediatric age group. So when we see the impact of migraine, headache are often result in significant impairment to child quality of life. In fact, headache ranks third among illness causing missed school days. It can interfere with child academic performance, home life, friendship, leisure activity, and the ability to learn. So after seeing the magnitude of primary headache, let's look at the pathophysiology of headache, specifically migraine. The first inciting step for the migraine headache is increase in metabolic activity, either through emotional stress, metabolic deficiencies like hypoglycemia, no missing breakfast or lunch, lack of exercise, change in weather in female menstruation, and in a condition where having a low energy state will trigger the trigeminal nucleus to release three important neurotransmitters, importantly CGRP. Now most of development in new migraine treatments are going towards the direction of CGRP blockers. There are monoclonal antibody targeting this substance or blocking this substance. Nitric oxide is another important neurotransmitter in the pathophysiology of migraine, and serotonin blockers has been used as a treatment for migraine headache. So after the production of this neurotransmitter, patient, especially patient with aura, will develop spreading of cortical depression starting from posterior to anterior. Posterior means from the occipital part of the head to the anterior. This is the propagation of the cortical depression. And when we see symptoms of migraine headache with aura, you will see there is a manifestation of visual aura followed by sensory, followed by motor and speech. That depicts the propagation from posterior to anterior. So this activation of neuronal system will activate compensatory trigeminal nerve mediated vasodilatation. This vasodilatation is mainly responsible for the pain associated with headache. So when we see the patient with headache, our first concern, most of the time, we emphasize on secondary headache, and our differential, traditionally we classify, or our mind work in differentiating, is this primary or secondary type of headache? In case of primary headache, we are saying the headache does not result from any specifying underlying structural causes. This include from the primary headache, migraine headache, tension headache, clustering headache, and other types of primary headache. The most common one in pediatrics are migraine and tension types of headache. And secondary headache results from underlying medical condition or underlying structural condition like space occupying intracranial tumor, tuberculoma, meningitis, sort of medical condition give you secondary headache. So as a physician, we are concerned about to rule out the possible causes of secondary headache. So history is the most important thing differentiating primary from secondary headache, and the diagnosis of primary headache is mainly by your clinical evaluation with your history and examination. So key features differentiating primary headache from secondary headache include length of illness. If the illness lasts more than 6 months, for example, a child complaining of headache for the past 2 years, and it has been more frequent in the past 6 months without any neurological deficit, then you can consider this likely to be a primary headache. The other is if the temporal pattern of the illness, like recurrent or daily pattern of headache, in between getting back to the baseline function. For example, yesterday I had a headache with severity of 8 out of 10. Today I'm okay for the consecutive 3 days and I have another episode of headache. So this pattern, recurrent pattern, tells you more of primary headache. If it is progressive kind of headache, headache was severity 3 months back, progressively 5, 10, now disabling in qualities, and it tells you it's more of secondary type of headache. Location, most of the time primary headache, patient complain in the frontal part of the head. In secondary headache, it's more of in the posterior part of the head. So in pediatrics, I ask them, where does it hurt the most? ህፃን ሲመጣ የቱ ጋ ነው በጣም የሚያምህ ብለን ስጠይቀው it tells you, it puts a child put his hand in anterior part of the head, tells you it's more of anterior or frontal or temporal part of the head. The other important thing is quality. Quality is difficult to describe it in Amharic, but I would say for a kid, is it hammering you በመዶሻ እንደተደበደበ ነው ወይስ ድው ድው እያለ ነው የሚያምህ ወይስ ጭምቅ አድርጎ ነው የሚይዝህ? Tells you the quality of throbbing or squeezing in quality. When asked about pressure, where does it hurt the most? A child will put his hand over his head and putting two hands, let me show you with this video. When he puts the head in, it hurts over here, then it tells me there is some pressure feeling over his head. Time of the day, anytime, will tell you primary type of headache. Early in the morning or upon awakening tells you secondary kind of headache. So I need you to keep in mind secondary headache patient can have awakening most of the time in the morning. But in primary case, kids can be awakened due to migraine or migraine headache in the middle of the night. So if it's always upon awakening or at night, then you should be suspicious about secondary type of headache. But if it's occurring anytime, sometimes at night, sometimes at the day, then it tells you likely to be the headache's primary type. Associated symptom, nausea and vomiting. So nausea is more common with primary type of headache. ያቅለሸልሸኛል ግን አያስታውከኝም. It tells you it's more of primary type of headache. If a kid says vomiting and the vomiting is projectile in kind, then it tells you there is raised intracranial pressure. And the presence of aura, suggestive of primary headache. So we discuss on the pathophysiology going from posterior to anterior due to cortical spreading of cortical depression, then it's more suggestive of primary headache than secondary headache. In secondary headache, you will see diplopia. So in younger patient, our families didn't concern us. They might complain about headache, the frequency of headache. This history, you can get it from the parents. But if they are, if you ask them about our family might not tell you. So I tend to ask during the headache, what does you see to the kid? So kids might say, I don't see the face of the person when I have the headache, or the blackboard or the screen looks hollow in between. That tells you there is some features of scotoma in the headache, or doubling during the headache period might suggest diplopia. Another important feature, photophobia and or phonophobia is an important feature. So when you ask about the photophobia in kids, it might be difficult. So you might ask the behavior during the headache. So if you ask the parents, what behavior or what character does he have during the headache, he tends to be go away from other kids, he goes to his room or to his bed and prefer to sleep. Then it tells you he has sort of photophobia and phonophobia. So most of the time ask if they are communicative. እንዴት ይሻልሃል ከልጆች ጋር አብረህ ስትጫወት ወይንስ ደግሞ ለብቻ ስትሆን? Then they might tell you, I tend to prefer being alone and to cover my eyes during the episode of the headache. So this is also another important graph depicting the pattern of the headache. So if the headache is acute in onset and increasing severely within short period of time, this is secondary type of headache. So let me give you another example. The name is changed. I have seen a patient who's Arsema. She is around 12 years old female patient. She visited our hospital having severe worst kind of headache in her lifetime. She was not able to communicate. She was agitated. So when I asked the parent about the history, she was okay last night. She studied up to 3 a.m. a night. Then she takes 3 hours nighttime sleep. When she wake up at around 6 p.m. She developed severe headache. So it tells you that this is acute, maximum at the onset, and you need to consider something vascular kind of headache. So for this patient, we had a brain CT scan. It showed intracranial hemorrhage. So maximum severe type of headache goes for acute secondary type of headache. So if you see this pattern, there is headache, severe type of headache. In between the patients, okay, again another headache. So this tells you primary type of headache. The severity when during the onset more or less similar. In between, getting back to the baseline neurological function, then it tells you this is primary type of headache, and your approach should be in such manner. A headache, a chronic type of headache, progressively worsening over a period of time. So if you ask a family, 3 months history, initially it was okay, progressively worsening a period of time, then you need to look for secondary type of headache. Chronic non-progressive headache, it could be due to primary headache or secondary headache. You need to look for clues suggestive of primary or secondary type of headache. In primary headache, if the pattern is like this, like there is a baseline severity, always I feel the headache, but in between there are bouts of higher severity, then you need to consider this a pattern goes with primary type of headache. as a pattern. So cause of acute headache, it could be, I think every one of us encounters this kind of headache following upper respiratory tract infection, dental procedure, endocrine disorder, following meningitis, encephalitis, following substance abuse, intracranial hemorrhage, toxic ingestion or exposure, subarachidonic hemorrhage, sometimes diet like nitrite, they might cause acute kind of headache. The cause for chronic headache, like migraine or tension or cluster type of headache, you have seen the pattern of primary headache can present with the chronic pattern. But if it is chronic but progressively over worsening a period of time, then you need to consider brain tumor. And if it is following trauma, you can consider post-concussive syndrome, hydrocephalus, progressively worsening a period of time, then it tells you there is a secondary headache. So brain abscess, idiopathic intracranial hypertension, medication, rebound headache, this can go with chronic headache. Most important thing, one of the headache pattern that might confuse you with primary headache is idiopathic intracranial hypertension. So idiopathic intracranial hypertension, the headache is worsening during night time, might awaken and worsen during morning time with associated vomiting, and it might associated with blurring of vision or tunneling of vision. Again, you might confuse it migraine with photophobia symptom. But if you ask the pattern, the duration, and when worsened, like nighttime only and upon awakening, and visual symptom is related to the headache and doesn't really resolve with the resolution of the headache, then it goes for idiopathic intracranial hypertension. Then when you suspect idiopathic intracranial hypertension, ophthalmologist evaluation is very important in differentiating with the primary headache. Now we talked about the differentiating feature and our differential diagnosis primary from secondary headache. Let's dive into primary headache. So when you say primary headache, we are talking about migraine, tension type headache, trigeminal autonomic cephalalgia, cluster headache are all examples of primary headache. Patient may also present during their first episodes of primary headache. That's where it gets challenging. So our classification of headache and characterization of headache is primarily from the International Classification of Headache Disorder. Still, it's in the third edition. They are working on to develop the fourth edition alpha version, but it's not yet published. So the first one and most important one to talk about is migraine type of headache. Migraine is in general classified as with aura and without aura. Migraine without aura, also called common migraine, comprises 60 to 85% of migraine. Migraine with aura accounts for the rest of migraine. So migraine without aura, these are the typical clinical feature lasting 40 to 72 hours. So most of the parents complain about headache. And when I talk with him, do you have headache now? Yes, after a few minutes, he says it goes away. Then it's less likely to be migraine type of headache. So typically children complain of headache in bilateral location, which is very differentiating from adult. Adult complain unilateral type of headache, either in frontal or temporal area, and usually aggravated by physical activity and are often accompanied by nausea, photophobia, and or phonophobia. So one of the things I tell to my patients is migraine lacks routine. So when you are getting out of your routine, sleep routine, diet routine, exercise routine, coffee routine, then you will get your migraine back. So whenever changes in your routine, you can expect the occurrence of the migraine headache. So according to the criteria, it should be fulfill all the A to C feature to consider this the headache is a migraine type of headache. So the duration is important, lasting 1 to 272 hours, and headache has at least one of the following feature, either bilateral or unilateral. So this is easier to get. The quality is difficult to get. So pulsatile ይመታል የሚለው will tell about the headache. The severity has to be moderate to severe. So asking the severity is one of the challenge in migraine headache. So I usually say for kids, 0 is when you are having a happy day, no headache, and 10 is rather than having this headache, I would rather losing everything I have. So the severe headache is here, the normal days here. Where do you put from 0 to 10? So most kids tell 6 to 8. So immediately ask them, what's your headache now? So considering his talking, his style, his mood, most of the kids say now I am having 3 to 4. Then I can assess, he's assessing his headache severity very well. Then you can grade the severity of the most frequent pattern of his headache. So aggravated by routine physical exercise, or it can be aggravated by lack of routine activities. At least one of the following should accompany the headache, either presence of nausea or vomiting, nausea being the most common, photophobia and or phonophobia might be there. As I said earlier, you can assess it from their behavior, tendency to prefer alone in dark and quiet place. So migraine with aura, the neurological symptoms usually develop over 5 to 20 minutes and lasts less than 60 minutes. So the neurological symptom means the visual, the sensory, the speech symptom, which gradually develop and gradually abate, but the headache will last. So initially, the symptoms of the neurological symptom comes, then the headache will follow, and the headache lasts longer than the neurological symptom. So this is based on the IC-HD criteria for classification of pediatric migraine with aura. So migraine, the talk or the teaching is ask the families about describe, or ask the kid to describe about his headache and listen. I will give about 10 minutes to describe about the headache, but aura symptom should be elicited for pediatrics. Otherwise, they will not tell you. So sometimes some kids might draw their symptoms during the headache, the scotoma, the flickering of light, the spots of light. Description will be elicited. Otherwise, the families don't, because they doesn't know about it, they might not tell you, or they might not even ask the kid about the presence of the aura symptoms. So fully reversible visual symptom, including positive feature like flickering of light, spot lines, and negative features or vision loss is one of aura symptoms. Fully reversible sensory symptoms and fully reversible dysphasic or speech disturbance. I only encounter 1 or 2 kids with the sensory symptoms or dysphasic symptoms during the headache. And at least 2 of the following features like homonymous visual symptoms, which is very difficult to elicit in kids. At least 1 hour symptoms developing gradually over greater than 5 minutes and abates less than 5 minutes, and not attributed to other disorders. So this is very important statement. So sometimes migraine without aura needs keen evaluation, because we might confuse it with occipital lobe epilepsy. So kids with occipital lobe epilepsy might have the aura symptoms, the visual aura symptoms with the headache. So in this case, EEG might be important, and also the duration is important. With migraine, the duration, at least the headache duration tends to last longer. For with occipital onset epilepsies, the duration usually less than 5 minutes. They will have the flickering of light symptom followed by the headache, which lasts for brief duration. It's more of suggestive of seizure than the migraine type of headache with aura. Another important type of migraine, which is very rare but worth mentioning, because most of physicians tends to work them up without having positive symptoms. So last week I've seen a 9-year-old female patient who has symptoms of tinnitus and headache over the occipital area. So primary in young adult, but present 3 to 20% in childhood migraine. The aura that clearly originated from the brainstem and or both from the hemisphere, but lack the motor weakness is suggestive of basilar migraine. The aura may consist of dysarthria, vertigo, tinnitus, hypoacusis, diplopia, ataxia. Unlike the pain of typical migraine, the basilar type of migraine can be located occipital. So she's complaining of headache around the back of her head, And during the headache, she heard some buzzy noise. So the father was worried, visited a different hospital, MRI was done, which was normal. Then they referred her to during the episode, the father also told me she become fuzzy, like she tends to be quite fuzzy. Then after few hours, she returns to her baseline activity. So this tells you the possibility of basilar type of migraine. Another very rare, but worth to mention is familial hemiplegic migraine. So in familial hemiplegic migraine, take home message, you need to rule out the possibility of stroke. Then if stroke is ruled out, then you can consider familial hemiplegic migraine. Another important concept is status migrainosus. So status epilepticus is there, status dystonicus is there, then status migrainosus is when migraine lasts more than 72 hours despite taking medication, then you can consider it status migrainosus. So after saying the above point about migraine headache, let's talk about tension type of headache, which is a differential of primary headache, migraine headache. Tension type of headache is this most frequent type of primary headache in pediatric population overall. Typically occurs during adolescence and is more common in female population. Generally, patients describe tension headache as constant pressing or tension. ውጥር አድርጎ ይይዘኛል ነው የሚሉት usually over the bilateral temporalis muscle and often extends to the neck and upper back. It's not always easy to differentiate migraine from tension type of headache. Some children can have both headache, migraine headache with background of tension type of headache. And usually episode lasts 30 minutes to 7 days, and the pain is described as mild to moderate. Tension headache occurs most often on weekdays and in the daytime hours and frequently progress throughout the day. So last week I've seen one kid, he's very expressive about his headache. He says there is tightening around by temporal area, but the mother told me the headache always occur from Monday to Friday. It disappear over the weekends, and it tells you this likely to be tension type of headache. So this is the ICHD3 criteria for tension type of headache. One thing is we can classify infrequent episodes of tension type headache with frequent episodes. So if it's occurring more than one times in a month, then you can consider frequent type of tension type of headache. Headache duration 30 minutes to 70 days. So he's saying he's having the headache every day in the week, sometimes 3, sometimes 4, other times 5. So it's with lower severity, but occurring for 5 days. So 30 minutes to 7 days is one of the criteria for tension type of headache. The locations, at least two of the following criteria should be fulfilled: bilateral in location, pressing or tightening in quality, and the severity is mild to moderate in intensity and not aggravated by physical exercise. So tension type of headache is associated with some form of tension for a kid, school activity, fear in the school, family, distressing issues. That tells you the possibility of tension type of headache. There should not be nausea or vomiting, and there should not be more than photophobia or phonophobia, but not both. So to say a few points about cluster type of headache, which is very rare in pediatrics. It occurs in cluster, having autonomic symptoms like rhinorrhea, increase in lacrimation, and change in skin color. The episode is shorter interval, which is another form of primary headache in pediatrics. So coming to evaluation, we more or less talk about the history part earlier. So to discuss it in detail, a complete history, physical examination are necessary in evaluation of headache. Abnormality must not be missed, as they may signal underlying life-threatening disease. When taking history, we must not use leading question, but should allow the patient and his or her family to describe the pain. So if you, typical Ethiopian family will not say no to your question. For example, if you ask about, does he have tightening over ear? They will say Yes. Does he have headache over here? Sometimes he have headache over there. Does he have fear of light? I'm not sure. I never asked him, but he might have. So to avoid those questions, first collect the history from the family, then especially with aura symptom, you can add your question later. So these are basic headache questions. I would be happy if I record one of the interview with younger children's having the headache. So whenever you ask, I wouldn't ask when did the first began having headache. So most of the time with headache, I will see the patient walking child to my clinic. I start conversation with a kid. So I will start asking this question. Time is very difficult for kids. So if you ask him, how frequent do you have the headache? He will not tell you. When did it start? He will not tell you. But if you ask about the characteristic of the headache, then you can have the conversation with the kids. So most of the time, typically I start the question asking the kids exhaustively all the possible questions. Then I would go to the parent to tell me the numbers, the duration of the illness, the frequency of the headache, and medication related. How often does he take medication? Ask this question from the family. So when did you first begin having headache? If he says it has been there for 2 years, now it gets severe in the past 6 months, then I would consider primary headache. Temporal pattern, sudden onset of first time headache, then it will tell you something acute going on in his head. And episodic headache, normal in between, tells you more for primary headache. We have seen the graphs previously. Where does your head hurt with your headache? Then most kids will put their headache and show you. And what do you headache feels like? Is it pounding? Is it tightening? Is it piercing in quality? Then they can associate with quality of the headache. What do you feel when you get the headache? What do you do when you have the headache? So most kids might tell you, I go to my room and sleep until the headache is over. That's important thing. How long do you headache typically last? Most of the migraine will tell you for 1 day, unless I sleep, it doesn't get resolved, and it's suggestive of more of migraine type of headache. During the school days, I feel the headache, but over the weekend, I'm okay. It tells you tension type of headache. Associated symptoms with your headache, they might tell you nausea. ሌላ የሚሰማ ስሜት አለ ከራስ ምታቱ ጋር ያቅለሸልሸኛል፣ ያስመልሰኛል፣ ብርሃን ሳይመቸኝም ኦር በፀሐይ መሄድ አይፈልግም። tells you about the aura. Dizziness, numbness, difficult to elicit, but you can ask. ራስ ምታቱ ሲጀምረው መንገዳገድ አለው፣ ብዥ ይልበታል፣ በአንድ በኩል መድከም አለው፣ ኦር ይደነዝዝሃል ወይ እጅህን እግርን will tell you about these symptoms. Is there any warning sign? Also is important to talk about the aura. ሊመጣ ሲል ይታወቃል እንደማለት ነው። ሌሊት ላይ መቀስቀስ አለው። I'm interpreting this into Amharic because we are taking the history from most of the time from Amharic speakers. So the headache ሌሊት ቀስቅሶ ያውቃል ወይ? Migraine headache ካላወቅን, but if it's always occurring at night or awakening the child, then you can consider secondary headache. Seizure and headache history goes hand in hand. So does he ever has a seizure? Especially convulsive type of seizures are easy to pick, but absent seizure or myoclonic seizure, you need to demonstrate. So ድንገት ፍዝዝ ማለት አለ ወይ? And you can demonstrate absence. They might say yes or no based on your demonstration. So activities, food, medication should be elicited during the history. So routinely, it's not recommended to have a routine laboratory checkup for headache. Most children do not require neuroimaging during the evaluation of the headache. So I might say the primary aim of this discussion or take-home message is to differentiate who needs neuroimaging or who doesn't. So most of the patient physicians tends to order neuroimaging in every patient having chronic type of headache. So this is the point of our discussion. So you need to take thorough history, examination, and you might put the patient on your follow-up. So headache history, you give advice, you will see the management advice, and follow after 2 weeks. If it is the same, after 1 month, If it's the same, then you can consider this is primary headache. So you need to keep in mind that our fear as a physician is not to miss any space occupying or intracranial tumors. So intracranial tumors, you can consider this pathophysiology. To have intracranial tumor, the tumor has to grow, occupy space, has to exert pressure. During that pressure, then that will be the cause for raised intracranial pressure and the headache. So 98% of central nervous system tumors present with change that is evident on your neurological examination. So you will always get, almost always, 98% mean almost always get focal neurological deficit, either hemiparesis, diplopia, persistent type of diplopia, aphasia, and other symptoms that stays beyond the headache period with associated headache. So you don't have to be afraid. A talking child explaining about his headache. Do I miss a possibility of intracranial tumor? No, you will not miss. As far as you take a detailed history and do a proper neurological examination. So, so you need to be exhaustive on your history examination. And if you are in doubt, you can put your patient on follow-up basis, like 2 weeks interval. You can see the patient if he's more or less the same, or if the headache is abating. And if you reassure the family, then you can avoid having unnecessary costly neuroimaging, especially for those physicians working outside Addis, referring the patient neuroimaging. You can avoid all this hassle. And one of the most most frequent thing I encounter, that you will order neuroimaging and there will be incidental finding. For example, arachidonic cyst, abnormal transverse sinus, or other abnormalities with neuroimaging, or most commonly headache. Even primary headache patient will have white matter abnormalities. So with that, now you increase your own anxiety, patient anxiety, and unnecessary referral. So after referral, we will have discussion about the neuroimaging rather than the headache, and also treatment for the headache. So you need to, as much as possible, take all these measures and avoid having neuroimaging. One more point from this slide. So in studies done in the West, timing of your referral for brain tumor doesn't affect the outcome. It's more dependent on the location of the tumor, the size of the tumor, the biology of the tumor, rather than whether early and late referral. Of course, I have reservation on these studies, because when the West says they are late in referral, it might be in weeks or months, but in our setting, it might be more than months. So as long as you put the patient on your follow-up, you will not miss anything by saying this is likely to be a primary headache. So findings suggestive of, or findings that prompt you to have neuroimaging include age less than 5 years, which is difficult for a patient to be cooperative and to do the examination. Recent onset with progression within the last 2 months. Abnormal examination finding, persistent abnormal neurological finding, changing headache pattern, like having chronic headache. Now he is having progressive daily headache, increasing in severity over the past 1 to 2 weeks. Then the headache is changing. History of trauma, immunosuppression, and other cancers might prompt you to have neuroimaging. Unable to describe the headache due to different reasons or altered mental status, that this is a given. Tender clasp or worst headache of a life, then it tells you this is the possibility of intracranial hemorrhage, presence of ventriculoperitoneal shunt, or having other syndromes, including neurocutaneous syndromes, prompt you to have neuroimaging. Choice of imaging, unless it's emergency. When I say emergency, it means when you suspect intracranial bleeding or intratumor bleeding, sudden change in pattern of the headache, the modality of choice, brain MRI, is the first line of investigation. So brain MRI is very good in assessing the tumor, brain tumor, posterior fossa abnormality, brainstem abnormality, Arnold-Chiari malformation. So CT is good for emergency, which is when you suspect intracranial bleeding. Now we talked about primary headache types, how to differentiate primary from secondary headaches, and when to reorder neuroimaging for a patient with primary headache. Now let's talk about a treatment. So treatment, there are 4 categories of treatment. 2 of them are more or less similar. There is active abortive treatment. There is daily preventive medication, which is secondary prevention, lifestyle modification, and behavioral change. So to give you a highlight on this slide, so active abortive treatment means I have headache now. A child is having headache now. Now we want to abort that headache. Preventive medication is we are not talking about the current headache. We are preventing the coming headache. By that, we are prescribing medication, or we can modify the lifestyle of the patient or behavioral strategies, which are important for acute and also preventive management. So acute abortive treatment, we need to create a treatment plan both at school and at home setting. So after evaluating a patient with primary headache, you need to put a plan. If the headache occurs at home or at school, you need to put the non-steroidal anti-inflammatory medication or analgesic at home setting and in a school environment. Consider including components of non-pharmacological options. We will see the non-pharmacological options. Consider fluids as part of the treatment. First line medication to take at onset and second line after 2 hours of the onset of the headache. So whenever a patient is having headache, I advise the family to initiate the medication as soon as the headache is developing. So the tendency in our setting, most of the family says, መድኃኒት አልሰጠውም በቃ ራሱ ይቻለው ይቋቋመው ይልመደው ብዬ የሚል is a common thought. So for migraine, pain is like not only for migraine, for other kinds of pain also, it's advisable to treat as early as possible. So hit hard, hit fast. So during the onset of the headache, patient should be put on first line medication. So we have different medication for abortive treatment. We start with monotherapy and progress to combination of acute management headache. Abortive treatment should generally be limited to 2 to 3 times per week. So if the patient is taking more than 3 times per week abortive treatment, taking paracetamol more than 3 times, ibuprofen or sumatriptan, this abortive medication, more than 3 times per week, then you need to consider, you need to start preventive medication than going on with abortive treatment. So if the medication, the headache despite your treatment lasts more than 72 hours, then we are talking about status migrainosus. Then we need to admit this patient and we need to start inpatient treatment. So we have different plans from different patients. So I can use for one patient plan A, the other patient plan B, plan C, or plan D treatment. These plans are not one after the other. For example, I know I guess you are familiar with management of status epilepticus. For status, we start diazepam, we continue progressively. For migraine, there are different plans. Plan A is mutually exclusive with plan B. So for those patients, new onset, moderate type of severity, I prefer plan A and plan B treatment. Plan A treatment, first line is to start fluid replacement. You advise a patient to take 24 to 32 ounce, which means you can multiply with 30 ml, so 1 liter of fluid or water at the onset of the headache, and you can start ibuprofen. If he is not responsive for ibuprofen, then you continue with administrating diphenhydramine within 2 hours. During this time, if the patient is at home, you need to tell him to avoid screen, home exercise, and the strenuous activity, to go to dark room, to have rest. You can use relaxation exercise. For adults, we advise yoga. For kids, you can stretch with the parent, can stretch with the kid. So if these 2 are not working within 2 hours, you can go for after 4 to 6 hours, you can add ibuprofen plus diphenhydramine. You continue on TID basis or QID basis of this medication. Plan B treatment, again, for moderate severity, you can go naproxen as a first-line treatment, the same parameter with ibuprofen, but now we are using naproxen than ibuprofen. Plan C treatment is mainly the backbone of this treatment is triptan, the fluid, the relaxation, the time interval oral, all are the same. So Plan D treatment, now we start with two combinations. So last time I had one patient who initially we started treatment with ibuprofen with diphenhydramine, but he was not responding for this treatment. We again repeat, second time he came, we again go with this treatment. But the patient was did require treatment with IV valproic acid, which is not available. So we go for loading dose of valproate, which is not feasible. So second time when he came, we from the outset, we start him on Plan C treatment with triptan treatment and with all the relaxation technique, putting in a isolated or a different room, decreasing the light, advising to take fluid, and after that, giving metoclopramide as to abate the nausea and vomiting. So this is the abortive treatment. So abortive treatment, most of the time, what you can do is ibuprofen is routinely available. Sumatriptans are available in our market, which is not approved for age less than 6 years by 12 years by FDA. But most of the children that I have seen are responsive for ibuprofen. Yeah, it's not good to tell a brand name, but good brands, especially with good quality, are better than the one you get the brutally. So initially, advise the parents to initiate either paracetamol link brand or ibuprofen as soon as the headache started. And if it's not relieving, then to give them diphenhydramine after 2 hours. If it's not controlled, to continue TID basis for 3 days of the medication. Even if it's controlled, I advise the family to take at least for 24-hour TID basis. Then if the headache relieve with sleep, in the morning the child is quite okay, then they can discontinue the abortive treatment. So when does the patient needs admission for headache management? If they continue to experience chronic severe headache, if they develop status migrainosus, if analgesic rebound headache despite normal physical findings, they need to be admitted. So these are medications that for abortive treatment. So you can refer for dosing. So this is abortive treatment for those patients who requires abortive treatment more than 2 to 3 times per week. And if the head, even if it's less than 2 times per week, but when the headache is visited the patient, if it is severe and disabling, or we call it PED-MIDAS score greater than 30, I will show you the PED-MIDAS score. Then you need to start abortive treatment. Patients that are prone to extremely intensive, prolonged, or hemiplegic type of headache, or basilar type of headache, or having severe type of aura, then those patients requires preventive prophylaxis treatment. The other indications are if acute treatment options are either ineffective, not tolerated, or contraindicated, or regularly overused, used more than 2 times per week. For patients suffering from frequent episodic tension type of headache and chronic type of tension type of headache, then this is those patients who requires prophylaxis pharmacological treatment. So the aim of our pharmacological treatment is to decrease the frequency of headache less than 4 times per month. So this is the PED-MIDAS score. You can access it over the web if you search PED-MIDAS score. So you are scoring the numbers, like if how many full school days school were missed in the last 3 months. So if he scores, I missed 7 school days in the past 3 months, then you will add. If it's less than 30, then it tells you it's higher severity and it requires preventive medication. So choosing preventive medication is very tricky. So we have a different option for preventive medication. Levetiracetam can be used, valproate can be used, amitriptyline can be used, topiramate can be used, ciproheptadine can be used. And even lifestyle medications are part of the preventive treatment. So from these 5 drugs, there is no study one is superior over the other. Valproate is not superior over topiramate. So our choice primarily depend on using side effect advantage. For example, 13 years old female who is her BMI is more than 30, I wouldn't start her on ciproheptidine, which is antihistamine that can worsen weight gain, or valproate, which can worsen as a side effect a weight gain. So we tend to use the side effect as an advantage. A child having sleep difficulty, I tend to use amitriptyline because it contributes both for migraine and sleep control. So for younger children less than 8 years old, we can use ciproheptidine, topiramate, amitriptyline, levetiracetam, or valproate. For older children, amitriptyline and topiramate can be used. For overweight or obese children, consider topiramate. If the patient is having allergies, you can use ciproheptidine, which is antihistamine. So we are killing 2 birds with 1 stone. So if the child is having sleep difficulty, consider amitriptyline. So whenever you start medication, start slow, go slow, and you need to optimize the effectiveness and decrease possible side effect experienced from the medication. So I tend to use it, for example, valproate for seizure, I start higher dose 20 milligram per kg. For headache, we tend to start a lower dose. And if it's controlled with a lower dose, we tend to maintain at the lower dose. Titration is not required as long as you control the headache with your medication. So for how long? Once started, for seizure with good control. So I am using the analogy of seizure. Maybe I'm familiar with seizure, but I think it's important to be retained in your memory. So preventive medication should be continued at their target dose, approximately 4 to 6 months. Then you can taper and discontinue slowly. So you need to have seizure freedom of 4 to 6, headache freedom of 4 to 6 months, and after that you can taper and discontinue the medication. Most of the time, I advise the family to start tapering and discontinuation during summer break time, where the child has the luxury to sleep well, to exercise well, to diet well. So most of the tapering takes place during school-free period of time. So this is a table showing you the medication dose, the formulation, the cost and relative cost, and the side effect. The cost, I take it from away. The doses, good dosing is described over this table, but the cost is not presented here. Otherwise, you can see the side effects. Side effects are important because our medication choices are based on the side effect profile. Propranolol also can be used. I have 2 patients on follow-up. One of the patient has a tremor, as we are also with the headache. So propranolol targets both the headache and the tremor. Another patient who has been on propranolol because she also has anxiety with the headache. So it has dual benefit. So this is the pharmacological preventive treatment. Non-pharmacological preventive treatment, there are ample studies showing a comparable studies. Like if families or child following this non-pharmacological treatment, it's as effective as pharmacological treatment. So most of the time, I don't initiate patients on pharmacological treatment from the outset. I will give them 1 to 2 months interval before initiating the pharmacological treatment. So during this period of time, I advise on them on relaxation technique, about feedback technique, about family relationship, school, leisure time activity, and combination of all these treatment. So you need to write this lifestyle modification as a prescription. So hydration at least 2 times the maintenance fluid the child is taking. For example, if the child is 20 kg, then he should take at least 3,000 ml. Most of the time, I tell the parent whenever he is going to school, give him 2 liters of water. He should finish while he is in the school. So when he came to home, he should finish the rest 1 liter. So he is able to take at least 3 liters of water. Exercise, you need to write it like 30 minutes every day until he sweats. So active physical exercise at least 5 times per week. Most of the time, I prefer every day rather. So a child might miss 1 or 2 days, it's okay. So sleep, the child should sleep at least for 7 to 8 hours. So most of the time, you need to advise to avoid bedtime bedroom screens. Like mobile should be out of the bedroom, television should be out of the bedroom. He should go at least 30 minutes before the routine period of bedtime. He should stay in the bedroom, then he goes into sleep. So most of the private school schedules are somehow demanding. So kids with headache, the last patient, she's around 16 years old. She tends to stay up to 1 a.m. at night, and she wake up at 6 a.m. in the morning. So this is tight schedule. So we need to advise and about the sleep hygiene and also the sleep duration. 7 to 8 hours of sleep is important. One of the gaps is children tends to follow this routine during weekdays, and during weekends they tend to sleep longer. So as I have said earlier, migraine lacks routine. So during the weekend, they might have their headache. So the advice is have a routine schedule, sleep onset time, sleep waking up time, then it should be fixed. And then as another advice is eat 3 healthy and well balanced diet. So most of the family, what should he eat and what he should not eat is the most common question you will encounter. So what I tell them is, again, migraine is like routine. He should eat his breakfast, lunch, and dinner, and most of the time it should be appropriate meal. Like if a child is taking some cake in the afternoon and missed his lunch, then he's likely to develop the headache. So the meal has to be adequate, and the time interval should be relatively fixed. Another important point is if the patient knows what, whenever I eat some peanut, whenever I eat some chocolate, I will develop this headache, then he should advise those diet. So these things can be catched with headache diary. So during headache follow-up, this is a headache diary, including did you have the headache? How long does it last? How bad was it? The treatment tried, what was helpful, and you can add other diet and other things, so you can assess the severity based on this graph. So we're left with 2 more slides. When to see your patient back in your clinic. So new onset headache, 2 to 4 weeks interval follow-up. So this is very important again, as we said earlier, to reevaluate your patient and to confidently rule out the possibility of secondary headache, and also to see the response of your child. So children with high frequency of headache, new change to treatment plan needs a monthly follow-up. Low frequency headache, 2 to 3 months interval follow-up. In a stable patient, you can see them every 3 months in your follow-up. So up to 1 year interval of your follow-up. So during this time, it's always good to reassure, good to revise their diary, and good to keep your advice on lifestyle modification, because people need reinforcement on their routine. When to refer to neurology, abnormal neurological examination, when you have serious concern about secondary headache, whenever there is worsening of the headache, especially despite your treatment and or not responding to the preventive treatment. So sometimes a patient coming to neurology clinic, especially adolescent with headache complaint, always need to rule out the possibility of depression. This afternoon, I have seen one patient who has headache, and he was complaining about his school circumstance. He was saying, all of the students doesn't like me, most of them bullied me. So in such scenario, we need to consider associated depression. So children will not say, I am depressed. Rather, they somatize it. I have headache, I have poor appetite, abdominal pain, sort of thing. So a patient with headache, especially adolescent, complaining of headache despite your treatment, despite your advice of lifestyle modification, if it is persisting, so you need to consider the possibility of mental health. So in conclusion, headache is a common condition in pediatrics patients. Primary headache type like migraine, tension headaches are far more common in children than cluster headache. History, and physical examination are the basis of a diagnosis of primary headache. There is no need for having laboratory or imaging if the diagnosis of primary headache is made with careful history and examination. Treatment is multi-level and sometimes might require multidisciplinary approach. Primary headache in pediatrics in general has good prognosis. These are my references. Thank you very much.
Thank you very much, Dr. Behaylu. That was an engaging and comprehensive presentation. You've managed to go over primary headache in pediatrics in a comprehensive manner, giving emphasis to the treatment. Thank you. So having said that, we'll directly proceed to the Q&A. My co-host, Dr. Mahalet, will shortly share her screen and we can go over the questions together. Thank you.
Thank you, Doctor, for the informative and very brief presentation. I'll be sharing some of the questions that attendees have proposed. Can you see my screen?
Yes, we can.
Okay, so the first question reads, what is the place of corticosteroids in the management of cluster headache?
So management of especially for emergency management corticosteroid, yes, there is a place of corticosteroid. There has been a study using methylprednisolone and also dexamethasone as management for cluster type of headache, even for status migrainosus as used as a treatment of corticosteroid. So this cluster headache is short duration type of headache. We can use it as an abortive treatment during the headache episodes. Considering pediatrics, I never had experience of cluster headache and also use of steroid for this condition.
Thank you. How can we prevent medication associated rebound headache?
So this is an important question. So most of the time, if the patients are taking or abusing the medication, then they will develop this rebound type of headache. So we need to strongly advise about the lifestyle modification, and we need to avoid giving the medication more than 3 times per week with headache. So if the patients are adherent to lifestyle medication modification, and if they are taking abortive treatment, either ibuprofen, paracetamol, triptan, or any other medication more than 3 times per week, then we need to go forward towards using the preventive medication rather than using abortive medication. By that, we can decrease the medications. So lifestyle medication and preventive lifestyle modification and preventive medications are important to reduce the rebound headache.
Next question is, what is the feared side effect of amitriptyline?
So amitriptyline has been used in pediatrics with migraine, especially older children. Still, FDA doesn't approve it for age less than 12 years. In a patient with prolonged QT interval, it's associated with arrhythmia. So I would say if I'm going to use amitriptyline for a patient in pediatrics patient, at least it's good to have one ECG recording.
What is the commonest aura type in migraine headache?
So in migraine headache, visual aura is the most common type of aura. From the visual aura, scotoma is the most common type of aura patients having. So scotoma for families, even they surprised whenever I ask the kid in my clinic about the aura symptom. The kid might not talk with the family because it's difficult for a kid to explain the whole features of the image. So visual aura is the most common type of aura in pediatric migraine headache.
The next question, can migraine without aura initially convert to migraine with aura?
Migraine without aura initially. Okay, so initially, if it were migraine without aura, convert to migraine with aura. So most of common type is migraine without aura. But some patients with migraine without aura, especially younger kids, might have difficulty of expressing the aura symptom. So with time, as they get older, they start to describe their headache with the migraine symptom. So that might be considered as the changing of the symptom over a period of time. So might be it's more of expression difficulties rather than conversion, but of course there is a possibility.
The next question, how does obesity influence migraine chronification in adolescents?
Yes, so obesity is very important thing to address in a patient with migraine. So one part of lifestyle modification, especially if the weight gain is associated with the development of the headache, we need to address the weight gain. So it's strongly associated with the chronicity of headache, especially in adolescents, especially in female, and it will start to intervene with our consideration. So some of the patient can develop associated with obesity, idiopathic intracranial hypertension, which is also strongly associated with obesity, and so it's strongly associated. We need to advise in lifestyle modification, weight reduction, and when we consider medication, we need to consider those medication important for weight reduction, especially topiramate has a place in that line.
The next question, why do post-traumatic headaches resolve quicker in pediatrics than adults?
Regarding post-traumatic headache, I'm not sure about the adult patients. With pediatric patients, of course, they tend to have better prognosis overall. So I don't have reading about this for pediatric versus adult.
How effective is prophylactic migraine medication? Is it age and neurobiology dependent?
Yes. So prophylactic medications are very effective in pediatric patients, even than adult patients with prophylaxis use. So with prophylactic migraine medications, including all the, so if you able to see the anti-seizure medication, and currently there are new treatments like monoclonal antibody targeting CGRP protein, and also there are also new novel treatments based on the pathophysiology. So they are effective in controlling the headache. They are as effective as lifestyle modification, and the neurobiology of migraine, especially with aura and without aura, by now is not are able to differentiate between that. But otherwise, it doesn't dependent on the treatments are not dependent on the neurobiology of the patient, at least for the time being. But in the future, the direction is going towards the a targeted treatment for specific patient with specific neurobiology of treatment. In age, regarding the age, yes, pediatric patients are highly responsive. Up to 80 to 85% respond well to abortive treatment, prophylactic treatment.
Thank you. And the last question, in what group does the abortive pharmacology treatments can be used, and in whom are they contraindicated?
So abortive treatment can be used as young as you can diagnose primary headache. So in younger age group, especially less than 5 years, it's very difficult to diagnose migraine. As you can guess, migraine is diagnosed with history. So it's very difficult to pick a 3-year-old child and to say this is a migraine headache, unless it describes it. So most of the family will tell you he has nausea, especially with nausea and vomiting. Most patients missed and visited gastroenterologists and neurologists or pediatrics with interest with headache management. So in that case, like having cyclic type of vomiting, headache, fuzziness, and it relieves after he sleeps, and the frequency occurring within a week or 2 weeks interval, and the severity is the same, then you can consider in that age group as headache. So as far as you can safely rule out the possibility of primary headache, the secondary headache, you can start at any age. But the choice of anti-migraine medication is dependent on the age group. So for younger children, most of the drugs are not FDA approved, the preventive medication. So we tend to use by extrapolation medications that can be used for seizure in age group less than 6 years. For example, levetiracetam, valproate, even topiramate can be used for younger age group. So there is no absolute contraindication as far as you are sure you are managing the primary headache.
Okay, thank you, Dr. Behaylu, for answering all the questions and also for the presentation. Now the host, Dr. Tadea, will take the floor and the quiz link will be shared. And after attempting the quiz will be discussed with you again. Thank you.
Okay, thank you very much, Dr. Marit. Thank you very much, Dr. Behaylu, for addressing all of the questions in a comprehensive manner. So we'll be sharing the CME Quiz link here, as well as on our dedicated Telegram group. Okay, the first question reads, which one of the following clinical feature is suggestive of secondary headache? A is focal neurologic deficit, B is severe type of headache, C is a strong family history, and D is having photophobia and phonophobia.
Okay. So can I ask how many percent answered it right correctly?
Sure. So I hope you can see it here.
Yeah. So I think most of the participants get it right. So focal neurological deficit associated with secondary type of headache. Here, strong family history is associated with migraine. So migraine can have family history of up 30 to 60%. So most of the time I ask the family, is there anyone in the family, especially parents, having a headache? They say no. So I tend to ask, what about when you were young, like during adolescent and early 20s? They say yes, during that time I had headache. So when you ask family history, ask during early use period of their time.
Okay, thank you very much. The second question reads, a 12-year-old female patient presents with a frontal headache occurring twice per week for the last 3 months. The headache has a throbbing quality with a severity of 9 out of 10 and lasts for 27 hours. She needs to lie down in a dark, quiet room. And at the onset of the headache, she experiences tingling in her left face, left arm, and left leg for 10 minutes. So what is the likely diagnosis? The first choice is migraine without aura. B is migraine with aura. C is brainstem mass lesion, and D is CNS tuberculoma.
Again, it's well answered. So you can see from the question, if you follow ICHD criteria, the headache occurring twice per week for the last 3 months, it tells you it occurs more than 2 times. The quality is throbbing and the severity is severe, and the duration is 27 hours, which is between 2 to 72 hours. And associated symptoms, she has photophobia, staying dark, quiet room, photophobia, and she also has at the onset tingling sensation in the face, left arm, leg for 10 minutes, and it resolves. So it's the aura symptoms followed by the severe type of headache, which goes with migraine with aura.
Thank you very much. The third question reads, which one of the following requires a neuroimaging? The first choice is a 10-year-old with headaches of 2 years with similar quality and severity. The second choice is a 14-year-old having a headache of 2 years worsening during menstruation. The third choice is a 4-year-old child with episodic vomiting and progressively declining neurologic. Let me switch to the other view. Progressively declining neurologic function. And the fourth choice is a 13-year-old with a 2-year history of headaches, taking NSAIDs almost daily, but the headaches no longer respond to medication, and the pain remains consistent in quality and severity.
So I'm happy, like 95% of participants get this one right. So the first one, 10 years old with headache, 2 years, similar quality and severity. So this is chronic headache, but the severity doesn't increase. So it's more suggestive of chronic type of headache, which is more of primary type of headache. So the second one, at 14 years old, having headache of 2 years worsening during menstruation. So some of female patient with migraine has bouts of worsening of the headache during the menstruation period. So this is also a feature of primary headache. So progressively declining in neurological function suggests underlying neurological process, and it's indication for neuroimaging. Another is 13 years old with a 2 years history of headache attacks. So this patient needs, as you can see, lifestyle modification and preventive medication treatment. And also now she's developing, apart from the primary headache, medication overuse headache. So the management has to address also the medication overuse headache apart from the primary headache.
Thank you very much. The last question reads, 14-year-old female patient with frontal headache occurring twice per week for the last 3 months, having a throbbing quality and severity of 9 out of 10, lasting for 27 hours, needs to lie down in a dark, quiet room, with tingling in her left face, left arm, and left leg at onset of headache for 10 minutes. Her BMI is 29 kilogram per meter square. What preventive medication should be chosen for this patient? The first choice is ibuprofen, the second is sumatriptan, the third is valproate, and the last is topiramate.
So I think everyone need to read only 64%, of course, above average responded this question rightly. But I think I advise you to go through the management part again. In this question, you can see that the patient is having 2 headache per week for the past 6 months, which means every week 2 times, at least 8 severe headache per month. So this patient requires prophylaxis treatment, both lifestyle modification plus preventive medication. So this is not about abortive treatment. So ibuprofen, sumatriptan, naproxen, diphenhydramine, all are abortive treatment. They are not preventive medication. So the first 2 are out. So from C and D choice, we depends on side effect profile. So her BMI is 29. It means at least she is overweight. So for this patient, we tend to prefer the medication side effect has a dual benefit apart from controlling the headache. So that's why topiramate is the right answer. Thank you.
Okay. Thank you very much, Dr. Behaylu. These were the quiz questions that are attempted. So on behalf of Yetena Weg and Ethiopian Medical Association, I would like to extend our heartfelt gratitude to Dr. Behaylu for his insightful and engaging lecture on primary headache in pediatrics. We are especially grateful for your time and effort in contributing to this educational session. It's an honor and a privilege to have you with us. Thank you. And to everyone that has attended thus far, thank you very much. We have another webinar coming up the next weekend. So you can closely follow our social media and you can register and attend that webinar as well. Thank you and good night.
Thank you very much for you and for Yetena Weg and all the participants.
Thank you very much, Dr. Behaylu.